We want to welcome all the facilities. We have a lot of facilities: Chilanga, Kafue Estates, Mukumi, Beshi, Arthur Davidson, Railway Clinic, Ngombe Health Center. We have Sichili. But we also have a lot of individuals joining us. We want to say welcome. May people please wave at us. I see the HNP class of 2019. If they can hear us, please wave so that we make sure that we are all here. Thank you so much. In the hub today, we are joined by our Lusaka School of Nursing, HNPs. We also have people from the Pediatric Center of Excellence, Adult Center of Excellence, and our expert today is Dr. Peter Minchella. He's the CDC lead on the HIV recency testing surveillance protocol. He's going to talk to us about what HIV recency testing is. But before we go into that, I'm Sombo Foloshi Mkombwe in the hub, and we have David, who will give us the recap for today. A special welcome to Nomsa. We missed her for almost a month. She's a great eco coordinator. This takes a lot, and she does a great job. We are happy to have you.
Okay, good afternoon, everyone. Just a quick recap of what we had for last week, as we were looking at the management of an HIV-exposed infant. So firstly, the definition was very important because even when it came to polling questions, some of us got that wrong. So an HIV-exposed infant is one that is born from an HIV-infected mother but has no infection, no HIV infection, that is. And then several points were also raised that all HIV-exposed infants should receive postpartum AZT 3TC plus NVP as prophylaxis to reduce the risk of mother-to-child transmission of HIV. Then we also talked about the duration of this prophylaxis, and that came out strongly that the duration depends on the viral load of the mother, which should be done within the 4 weeks before delivery, and also on the duration of ART that the mother would have been on at the point of delivery. All HIV-exposed infants should receive prophylaxis, ARV prophylaxis, that is for 6 weeks, that is for those that are low risk, and then 12 weeks for those that are high risk. And then concerning the dissolution of this AZT3TC dispersible tablet, we were reminded that it should be dissolved in 6 ml of cool, clean water, not multivit, but clean water. And that suspension that results should be used within 10 to 14 days. Then breastfeeding infant whose mother gets infected at a postpartum should definitely receive AZT3TC plus NVP prophylaxis for 12 weeks because that one is a high risk. And then the ART prophylaxis in the infant should be reinitiated in the baby who is still breastfeeding from a mother whose viral load becomes greater than 1,000 copies per ml, even if the infant has taken prophylaxis for 12 weeks. And then the baby born to a non-HIV positive mother who simply refuses ART should receive prophylaxis until the confirmed final outcome of the HIV is negative, and that after complete cessation of breastfeeding. However, please take note that as a child is on the prophylaxis, we should always, that is extended prophylaxis for those that are high risk, even when they're supposed to have stopped because of the viral load or the mother's refusal to be on ART. Always check for anemia and neutropenia while the child is on this prophylaxis. And if there is anemia and presence of severe neutropenia, please stop the AZT3TC and only continue with the NVP, and this should go on until 7 days after complete cessation of breastfeeding. But please take note that cotrimoxazole may also cause side effects that are similar to what we have just talked about, that is anemia and severe neutropenia. So always rule out that. Thank you very much. Over to you, Sombo.
Thank you so much, Davis, for that. I must say that we also have experts. I'm so happy. Dr. Aaron Chivemba has just joined us. We have Dr. Zico Lunga from Infectious Disease Center, and we have Dr. Francis Peter.
Good afternoon, everyone. As Sambo mentioned, the topic for today is recent infection surveillance. And we have 3 learning objectives. Number 1, to appreciate the motivation behind implementing recent infection surveillance in Zambia. Number 2, to understand the principle behind the test for recent infection. And finally, to become familiar with plans for rollout of recent infection surveillance in Zambia. So starting with objective number 1, again, the motivation behind implementing recent infection surveillance in Zambia. So as we know, Zambia is approaching universal treatment coverage and viral suppression of PL-HIV. You can see in this figure the yellow line, which represents HIV prevalence, and the red line, which represents ART coverage. The red line is approaching the yellow line, meaning we're approaching universal treatment coverage. In this context, indicators of ongoing transmission, as opposed to just prevalence, will become increasingly important. And one of the reasons behind that is because there are limitations to HIV prevalence. So changes in HIV prevalence may be due to things like PL-HIV living longer, HIV-related deaths, or new infections. And with increased survival of PL-HIV, HIV prevalence is not expected to change significantly, even with changes in incidence. So we see that in this figure below. The yellow line, again, is HIV prevalence, and the black dotted line at the bottom is HIV incidence. You can see HIV incidence is decreasing over time, while HIV prevalence stays pretty stable. So this is an indicator that HIV prevalence is maybe not the best indicator of how we are responding to the epidemic. So typically, traditionally, the way we measure ongoing transmission is through the incidence rate. And the incidence rate measures the number of new HIV infections among the population at risk over a given time period. And traditionally, the way we do this is through directly observed HIV seroconversion in a prospective cohort. And this is a very effective approach, but it's expensive, it's time-consuming, and it's really quite difficult to incorporate into routine HIV services. So kind of as an alternative, tests for recent infection are able to distinguish recent infections, which are those infections that occurred within about the last 1 year, from long-term infections, which are those infections that occurred longer than 1 year ago. And recent infection testing can give us a proxy estimate for new infection rates, and it can also help us identify what we would call transmission hotspots. One of the things that enables us to do recent infection testing is a new point of care test that actually gives results within a few minutes and simultaneously diagnoses HIV infection and differentiates between recent and long-term infection. And there's a picture there in the middle, but I'll discuss this a little bit more later. And these point of care tests are really important because they enable us to establish recent infection surveillance systems and really incorporate recent infection surveillance into routine HIV testing services. So part of developing a recent infection surveillance system is that you're going to get data on recent infections. And this slide is meant to give you an idea of kind of how we hope to use these data. So the first step there on the left is to detect recent infections. And this is really important for the reasons listed below. Again, these are infections that occurred within about the last 1 year. And people with recent infections generally have high viral loads. They generally have high-risk behavior because they don't know they're infected yet. And as a result of both of these things, there's a really high probability of ongoing transmission. There's actually data suggesting, excuse me, that about 40 to 60% of HIV transmissions are due to recent infections. And these people also generally know their recent contacts. So after we detect recent infections, we move to that second step of analyzing data in real time. So we want to know who was infected, who was infected recently, I should say, where they were infected, and if possible, why they were infected. After analyzing the data, we can then kind of target prevention, so design interventions based on these data. and move resources where they will be best utilized. And then hopefully that last step is to interrupt further transmission. So this brings us to the first polling question, and this is a true or false question. So the question is, as Zambia approaches epidemic control, prevalence will be a more useful metric for program planning than indicators of ongoing transmission. True or false?
You need to false. As Zambia approaches epidemic control, prevalence will be a more useful metric for program planning than indicators of ongoing transmission. As Zambia approaches epidemic control, prevalence will be a more useful metric for program planning than indicators of ongoing transmission. Or people in the hub, you are free to poll, because we'll also have to pick an answer. Okay, that's fine. So that it's interesting because even in the hub we have a 50-50. But when I saw this, I said, you're a very kind person because everything you talked about and then you poll. I tend to go the bad way. I first not teaching. So he's obviously talked about this already. But I'm seeing also almost a 50-50. Some people feel that you need some mics. Prevalence will be more useful, which is the new patients and the people that are dying, people are living longer. That's more useful than us knowing the ongoing transmissions, where our hotspots, who's getting HIV, where is it being spread? So it's 50-50. I'm going to end that. I'll share the results in a bit so that we see how we polled. Most people feel that it's false, but it's almost 50-50. Some people feel that it's true. I'll do them again. You can move on.
Okay, so should I just continue?
Yeah.
Okay. So now moving on to objective number 2, the principle behind the test for recent infection. Okay. And I'm going to talk a little bit about host virus dynamics during HIV infection. And I acknowledge there's quite a lot going on in this slide, but I want to focus on the blue line in the middle that's kind of increasing through the middle of this chart. And that line is showing the increase in antibodies over time following HIV infection. And what I really want to pull out is that kind of as time goes on since HIV infection, you're generating more antibodies and you have antibodies that are maturing. And one of the functional properties of antibodies is that word in bold on the right, which is antibody avidity. And I'm going to discuss that a little bit more. So antibody avidity is the binding strength of an antibody. And basically, as antibodies grow older, as they mature, they increase their binding strength. And this is a functional property of maturing antibodies, meaning it happens with all antibodies. And so because this happens at a relatively similar rate for all antibodies, we can use the time since infection as kind of a surrogate marker of infection. And so basically the idea is that we can distinguish someone that was recently infected because they have weak antibodies that aren't binding as strongly, versus those with long-term infection who have strong antibodies, who have high avidity antibodies. And the way we kind of operationalize so the way this is operationalized into an assay is it uses the principle of limiting antigen. So we see on the top here, those blue circles on the left are antigen. And in that top case, we have so again, the top has excess antigen, and so both the low avidity antibody and the high avidity antibody are able to bind because there's plenty of antigen there to bind. But if we limit the amount of antigen, which you see on the bottom, so there's only 3 circles there, only there's competition for binding, so only those high avidity antibodies are able to bind because they they have stronger binding strength. And so we're able to distinguish people with long-term infections versus those with recent infections by seeing which antibodies bind and which don't. And so initially this principle was incorporated into laboratory-based enzyme immunoassays. And there's actually one called the LAG assay that was used as part of Zambia that you may be familiar with. But more recently it's been converted into a lateral flow test, a rapid test, which you see a picture of there. And it's basically a test strip. It requires about 20 minutes to do the test. And based on the number of lines, you can tell if you have a long-term infection, a recent infection, or if your sample is actually HIV negative. So this rapid test accepts, excuse me, 3 different specimen types: whole blood, serum, or plasma. So it's fairly flexible. It has a few advantages. It's very easy to use. It does require some training, but really there's minimal technical skill involved. And there's no special equipment required. In terms of surveillance, again, this is a test strip. It can be stored at room temperature. It can be moved around quite easily. And so it really lends itself well to incorporating the test into routine services and creating a surveillance system. The test does have some limitations, and these are important to note. The first one is that interpretation of recent infection test results is challenged by factors that can cause false recent results. And by false recent, I mean that the rapid test is telling you that this person was recent, but in actuality, they have a long-term infection. And some of those factors are that variable immune responses at the individual level, variable performance of the assay across diverse HIV-1 subtypes, and also across populations that have naturally low viral loads. So that might include elite controllers, for example. And probably the most relevant one is current ART use. So if a patient is currently on an ART, that kind of causes issues with the test. So the way we get around this is by using an algorithm that includes a baseline viral load to reduce those false recent results. So we want to know if we find someone has a suppressed viral load, we know they're already on ART, and we can kind of adjust our results for that. Other limitations are that this test, again, it's not necessarily for HIV diagnosis, but it's also not yet approved for HIV diagnosis. HIV-2 positive specimens should not be tested, and it should not be used with specimen types like saliva, urine, or dried blood spots. So this is an example of that algorithm that I was just referring to. So the top box is kind of the routine HTS algorithm, and I think everyone's probably seen this before. And you see in the middle there, if you are HIV positive, the clients that are HIV positive move down to the box on the bottom, where they undergo the recent infection testing algorithm. So they get a test for recent infection. Again, this is that rapid test. And if they test recent, then they'll also get a baseline viral load test. And then you see those 2 boxes at the bottom. If they tested recent and had a viral load above 1,000 copies per mil, they're considered a recent infection. But if they tested recent and had a suppressed viral load, then they're reported as long-term. And this brings us to polling question number 2. So in addition to a test for recent infection, and this is multiple choice, sorry. In addition to a test for recent infection, which other test is included in the recent infection testing algorithm to reduce the likelihood of a false recent result? And the choices are CD4, serum creatinine, viral load, or Western blot.
So the second poll question is, in addition to a test for recent infection, which other test is included in the recent infection testing algorithm to reduce the likelihood of a false recent result? We can also vote. Okay, we have.
This is much better.
Yeah, this is much better. We have a kind of unanimous vote here, which is how it looks even here. So that's interesting.
It's not unanimous.
kind of, keyword being kind of. So we are seeing things like CD4. Is this included in the recent infection algorithm, which Peter just showed us? Are we doing serum creatinine? We need to sort of think how this would reduce your rates of false positive, because the first place, I don't know how a serum creatinine would tell you anything about HIV. Anyway, we have viral load and we have the Western blot. Something fancy. When I hear ELISA, Western blot, I'm shivering. I'm just really bad with immunology. Anyway, in addition to a test for recent infection, which other test is included in the recent infection testing algorithm, which Peter just showed us, to reduce the likelihood of a false recent result? Is it a CD4 count? Is it a serum creatinine? Is it a viral load? Is it a Western blot? So very interesting answers over there. I think Peter will take us through them. So that's how we voted.
Okay. Now moving on to the final objectives, plans for rollout of recent infection surveillance in Zambia. And before I get into rollout plans, I want to note that Zambia is not the only country doing this. So these are data from Rwanda, and these data were collected during about the last 1 year on recent infections, and they're testing in about 130 sites. And you can see those red dots represent recent infections, and the gray dots represent long-term infections. So from these data, which I think are pretty interesting, you can really see that most of the recent transmission is happening in Kigali. So maybe there's an opportunity to interrupt transmission in Kigali. So in Zambia, we want to do a similar thing, and we plan to roll this out under a research protocol. And you see the title there. I won't belabor this point. But the proposed kind of rollout plan in Zambia is really based on testing for recent infection at hub laboratories. So you see from the start that only patients greater than or equal to 15 years are eligible, and patients have to consent because this is research, of course. Those patients that are HIV positive and greater than 15 that consent will get a venous blood sample taken for safety labs. That sample will be transported to the hub laboratory. At the hub laboratory, you'll get the CD4, the safety labs, and preparation for a basal viral load. And you also undergo the rapid test for recent infection, which you see with those strips right there. From there, the sample will be transported to the viral load laboratory, where you would get that baseline viral load. And the data would be entered in the laboratory information system. So in most cases, this is DISA, the DISA system. From there, the data would be pushed to a central data repository, and then we'll be able to visualize it, hopefully in pretty real time on a dashboard. And one critical aspect of this is collection of the venous blood at health facilities for safety labs. So we know this is part of the guidelines. This is actually a screenshot from the guidelines. But in my experience, which is limited admittedly, this does not always occur at health facilities. So it's really critical for this process to collect that venous blood specimen. And other responsibilities that health facility staff will include obtaining consent and also completing the start of the laboratory requisition form. And so the plans for where to start were really informed by Zamfia. So these are data from Zamfia, which again included recent infection testing, though they're not the exact same test. And you can see in this picture, there's a red circle around a few cities in Copperbelt and also in Lusaka. So this is really where, at least a few years ago, Zambia was seeing the most recent infections. And so the plans are to start in Lusaka province and Copperbelt province. And this is a brief run through of the timeline during the next few months. So this is actually imminent. Next week, there will be a training of trainers in Lusaka. So the idea with this is to train master trainers who can then go train others. That will be followed by step-down trainings for laboratory hub technicians in Lusaka and Ndola, and then site activations. And we hope to start, assuming all goes well, we hope to start collecting data in late October. And again, the plans are to start at all facilities in Lusaka and Copperbelt first, and then from there we'll move to central and southern provinces, and from there to the rest of the country. So for a summary of key points, number one, unlike relying on HIV prevalence, and this is very relevant to that first polling question, HIV prevalence, which is slow to change, recent infection surveillance will enable monitoring of ongoing transmission. The second one, the point of care test for recent infection is based on antibody avidity, and again, that's antibody binding strength. And finally, plans to implement recent infection surveillance in Zambia are underway. And really, successful rollout will require engagement from both health facility staff and laboratory staff. And these are a few references. I want to point out the second one, which will actually bring you to a YouTube video. It's about a 5-minute YouTube video, and you can actually watch someone doing the test if you're curious about what it looks like. And discussion questions. So initially, what questions come to mind? How would you apply this new information? And how does this information relate to your experience?
Thank you so much, Peter. I'm sure you noticed that he raised a few discussion points. This was very interesting because it's a new term. So maybe we can go into the discussion point. Do we have any comments from Sichili about this test? I have a lot of questions, but I don't want to take over because it's easy for me to take over and I shouldn't do that. So what questions come to mind when we hear about this recent C infection testing? I know we have some typed questions, but I've unmuted Sichili, Joel, and Mr. Waluvita. Any questions? Hello?
Currently, we don't have any questions, Doc.
Oh, wow, you're better than me. You know, fancy words like basal viral load. We are used to routine and target, but that's fine, thank you. So we have some questions in the chat. Mundia, can you read some questions from the chat, please? Any comments? Dr. Tembo in Katete.
So, hi, Peter. In the case
just shout a bit.
Hi, Peter. In the case of reinfection of a LTI patient, what does the RI test give? Regards.
So that's an interesting question. So reinfection, I suppose.
Oh.
I don't have data on this, so I'm speculating. But I would anticipate that someone who was initially infected would have a higher viral load. But if they were on, assuming they were on ART, they would have a suppressed viral load. So we would, I guess I would assume it would be a long-term infection. But that's a good question. I mean, I admit there are many unknowns about this. This is new technology, and I think we have a lot to learn. And questions like that, I think, will be interesting research questions and interesting programmatically as well.
Okay, Dr. Shibaba, do you want to comment on that one? I know it's a bit clinical. The person is saying you already have HIV, you tested positive, then you now have reinfection.
Mm-hmm. This
fancy
to pick it.
You know, so it means that you have a mixed infection. You have the recent infection, but then again you have the long-term infection. Do you think this test will be able to pick this and that, the difference? Dr. Mpeta, any comments?
Yeah, because you see, I'm just looking at, are you getting a new strain of HIV? Because you already have the HIV infection and you have already produced antibodies. Some of them will be there for a long time. So it's the same infection, it's the same antibodies. So I guess it will show as a long-term infection rather than a recent infection, unless if it's by any means that it's going to be some of, typically different from the one that you had. Maybe HIV 2.
Although this test, I will say, this test is not recommended for HIV 2, yeah.
It's only for HIV 1.
But yeah. I think that's a good point. If it's phenotypically different, or if it's a different subtype, you might see some differences, but I would guess probably a long-term infection.
Good afternoon, team. I would like to know a bit more about the sensitivity and specificity of the recent test. Also, what is the gold standard test for the recent infection?
A good question. So I'll start with the first question. So typically, what the gold standard is used right now, and I don't know if it would be considered a gold standard per se, but the lag avidities of the enzyme immunoassay, which this lateral flow test was adapted from, is used as the gold standard. And there's pretty good. I don't have the sensitivity and specificity numbers at my fingertips, but I can say there's good concordance between the lag avidity enzyme immunoassay and the rapid test. So that being said, again, I'm going to go back to this false recent idea. In other countries that have implemented this, what they're seeing is quite a few false recents, and this is largely from people that are already on ART, but perhaps not admitting it, and then getting this test, and they're coming out as false recent.
Maybe Dr. Tembo, before we read another chat, any comments on this very interesting topic?
Yeah, my comment was my concern with regards if this test was used in the general population. My concern was its sensitivity and its specificity. How could it be described?
So, and one thing that I perhaps did not mention as much as I should have is this test will be for surveillance purposes only. So these results will not be returned to patients. They will not be returned to facilities. They will be for surveillance purposes only. But I can point you towards some of those links I had will have the numbers on sensitivity and specificity.
Okay.
I'm sorry, I don't have those.
So I'll allow Dr. Shibemba to comment on this discussion before we go to our next, on the application, how we will apply it.
Thank you very much, and good afternoon, everyone. This is a very interesting activity, and from preliminary data that has been done in other countries, it shows a lot of improvement in terms of how we can increase the yield of patients with HIV testing. So, like has already been mentioned, recent infections, these are the people who are highly transmissible. They transmit HIV highly than long-term patients because the viral load is very high in these patients. So it's very, very important for us to get that cohort and follow them up, targeted testing. Whoever has been exposed to this kind of people, we track them and test them, do viral loads on them, and then initiate treatment also. I think from a public health perspective, it's a good test, and we are excited that we are going with it, and hopefully the results from our study will be very helpful so that even other countries can learn from us. Thank you very much.
Thank you so much, Dr. Shibemba. It also made me calm. So I guess the next step will be full implementation. For now, it's just for surveillance protocol, for surveillance purposes, and I believe it's already pre-qualified. Is it approved by the World Health Organization?
It is not approved by the World Health Organization, which is part of the reason it's for surveillance purposes.
That's why it's just for surveillance. Dr. Zico?
Yes, I noticed on the limitations, there was a statement on advanced HIV as being a limitation. Could you make a comment on patients who have advanced AIDS, who are in the AIDS stage, and the antibody avidity? Is it affected by immune response?
So I do this. So I unfortunately don't have specific data on this either. But yeah, I think the antibody avidity changes over time to the point where the test is less useful, shall we say? But I can point you to resources on that. Well, that's a good point.
So Petauke will take your comment before we go to the next discussion point. Petauke.
Thank you. I would like to understand, Dr. Kavala talking, I would like to understand why are we excluding clients who are less than 15, while we know that our HIV transmission, it comes from old men to touch the girls who are around 15, then from there they go to young men. So why are we excluding those ones, the under 15? Why you can't consider like 14, 15 among those they are required to be tested? And yeah, I think that's the major question.
Okay, thank you, Bill. But I have a question before we answer that. So in terms of epidemiologically and hotspots, maybe if I tested an 8-year-old and for recent infection, do you think that's very useful data in terms of epidemiology and looking for spreading like an 8-year-old?
No, 8 years, no, but 14, 12, 13.
Thank you for adding that. Okay, thank you. So why are we picking people only above 15 years?
Yeah, it's a great question. So the primary reason is that the test has not been validated for those that are less than 15. So as I think that there are plans, as we get more data about this test, then it may be possible to move to including those that are 14, those that are 13. But at this point, the test has not been validated.
Okay. Thank you so much. I see Dr. Daniel Mwamba has joined us. We have Chris Niti. We have Oscar Mwinde. I think Oscar is joining us from the UK. Isn't it? Yeah, welcome. And I see we've had to use the other hub because it's very, very packed here. So how would you apply this new information? I think this is to all of us as a network, and all of us here in the hub, we have our HIV nurse practitioners. Any comments on how we would apply this new information, this brand new information? I think I saw Dr. Onoya. Any comments? I know he loves this type of thing. Dr. Onoya, do you have any comments how we would apply this new infection on this new information on recent infection?
Yeah, good morning, good afternoon, Dr. Somba, and good afternoon, team. In fact, it was, I was typing that question as well. So since you've already, so it would be good to hear from the presenter, what is the answer to that? How will it fit in the, how will this test fit in the actual screening algorithm?
You are a clever one. He wrote that question for us to answer. Now we are asking him again. He wanted to hear our thoughts. How will we apply this new information before he answers Dr. Onoya? So now, so what if I know that it's a recent infection? I know I saw Robert is at Creso. Dr. Robert, how will you apply this new information as a mentor? We need some mentoring here, this brand new information.
Good afternoon, everyone. We actually had a question or some concerns before we come to how we're going to apply the information. So I don't know if we could be allowed to go ahead.
It's okay, yours.
So the concern we had, the first one is when we say recent infection, is there a specific duration that is tied to this infection? Because we've just been hearing recent, long-term, and so that's one of the things we wanted to find out. Then there's also a concern from the group here for recent infection, and we do the viral load. And if the infection is really recent, won't we find a low viral load and which maybe distort the interpretation of the data that we have?
Okay, I like that question about what is a recent infection. I know he talked about it, but he needs to emphasize. But I think I'll let Dr. Chibemba answer the second question because I know he talked about it. I think Robert's question is, won't we find a low viral load in people with recent infections? According to Robert, he thinks the new infection, usually the viral load is low. Would you like to clarify that?
That's an interesting question of observation. I think from even research and even the data that we have seen that with high viral load. And that's why we are so interested in catching these people who have been recently infected so that we can prevent them from spreading the HIV.
Thank you so much, Dr. Chibemba. So, Robert, recent infections tend to have probably the highest viral loads that HIV positive patients can have, it's usually in the tens of millions, so they tend to spread more. So Peter, would you like to define what a recent infection is?
Sure. So a recent infection, as it's defined for this test, is one that occurred within the last 1 year. And that's based on data where they're basically following, they're seroconversion panels, and they're basically following conversion over time.
Okay. So 1 year. 1 year is the cutoff.
Yeah. Is it possible we show the strips and to see positive, negative?
I like that question because I always feel I'm the only person that would require a lot of thinking because it's sort of like the positive one is the one that's old, then the negative one is the one that's new. So I think let me just try to share those slides. But we have not answered what Peter wanted us to talk about. How will you apply this new information? Do you want to address the issue of how it will fall into the, like what Onoya said, if it was to become standard of care? Yeah. At which point do we do this? You want to address that?
Sure. So I think initially how we will apply this information, again, it will be for surveillance purposes only, and it will be, I presume, used on kind of a macro scale. So perhaps you can identify where transmission is occurring, and then there's talk about perhaps doing outbreak investigation. Okay. So investigating, trying to find out exactly where, like who's transmitting and trying to interrupt that. Perhaps when it becomes standard of care, when this becomes pre-qualified, it may become possible to return these results to patients, return these results to facilities and use them at an individual level. But that's a discussion that we will have in the future, I imagine.
I believe in this, in our surveillance for Zambia, we are not returning the results to the patients. I think it will end that you are HIV positive, you go into standard of care. The rest is for research purposes. I know there are countries that gave this result back to the client, and there were issues of people having a lot of, legal issues, like
legal issue or intimate partner violence. Yeah.
And that brings me to the thought, for me in my practice, I would think, I'm not a lab person, Dr. Shwemba, you can clarify. I think this would be useful in index testing. You know, if I'm in my 20s, I'm really not going back to people who I slept with when I was 15, isn't it? So this one tells me, if I'm a recent infection, please give us the list of people you had encounters with in the past 1 year. Because it kind of closes the window, because at the moment you ask, so where does index testing end? Is it 10 years? If this is your first test, you've never tested before, I would think even in index testing, this is gonna be a very powerful tool to help us just curb the numbers and say, we've indexed enough, don't trust the whole world. So anyway, if people want to comment on this.
Well, they can go ahead.
You want to talk about this?
It's fine.
I think Dr. Mpeta wanted us to. Do you want to ask a question again?
Yeah, I think Mundia wanted to get a clarification on how many lines you get when it's long-term versus recent. So it's like when it's long-term, you've got all the flashes on, right? And then if it's recent, you get one flash which is going to be off for long-term, isn't it?
Yes.
Yeah. Then HIV negative one is interesting because it looks like it's 2 lines, which could be confusing. Is that a line?
So the first one is not a line.
It's not a line.
It's a line, and this is just the paper.
Yeah.
Oh, okay.
And I apologize that the words are not aligned.
So, and you know, when people are used to 2 lines and then,
Do people want to explain the first line, the second line, the third line, so that we are all clear?
Sure. So the first line is the control line. And again, that's telling you if you're HIV negative or positive. But I'll say that test is not yet approved and is not to be used for that specifically. The second line is the V, stands for verification. And then the third line is long-term. And so if you have the 2 lines, that's a recent infection. If you have the 3 lines, that's a long-term infection.
And the second question you had, the effect of suppression and long-term ART on this, considering that the determinant is affected by that in terms
right. So if you're suppressed, basically that could potentially, so if, for example, if you've had HIV for a long time, you're on ART and you have suppressed and you're suppressed, you may come across as a recent infection, when in actuality you're a long-term infection. And that's due to the suppression is kind of messing with the antibody immunity, for lack of a better term.
Okay, thank you so much. I see Dr. Mundia is nodding. It's unfortunate the camera is not focusing on her. She's very interested. I know, Bill, you are alone in your echo room.
So audio is there.
Dr. Bill, I see you are alone in
Audio
your
is there, so you'll be able to
maybe we
hear.
should have just gotten you a phone for echo instead of a whole echo room, isn't it, since you're alone? But there's a question. Yes, I think you can handle this one. He says, how does the information that we've now all learned relate to your experience at facility level? I know you see a lot of patients.
Actually, the way you put it, that's what we're discussing here, to say it will help us when we're discussing about index. It means these clients that are found positive, we have to elicitate, and we just do that blindly. Actually, this test will help us to know that this one is it's a recent infection, so she has to lead us really to where she got it from or where he got it.
Yes, that sounds almost like you are going with spears, isn't it? But I think I'm told, but at least the data from other countries has shown that even returning to the client really has had very few consequences. But still, since we are still in our infancy, we've chosen that this information won't change your treatment. It won't change the ART. I'm so sorry, Bill. I see you with people, but I know I've seen an echo room that's empty, but I have 5 screens here, and I know we've been advised by Leonard on several occasions that we need to be now going into breakout rooms. Dr. Jinwala, do you want to prepare and share your screen as we go to our 4 questions? Dr. Jinwala from Mwembeshi, please get ready to share your slide decks. Is there a question? Yes, Chatonda. Mary, please go ahead.
Hi, can you hear me?
Yes, we can, Mary.
Okay, thank you. I just wanted to make a comment. I think it's been a really interesting discussion so far. Perhaps in my mind and from some of the conversations that we've had, perhaps the most important aspect of this recency testing is to help us target epidemic, our approach towards the epidemic a lot more. So we know Zambia has somewhere around 1.2 million people living with HIV or so, and we've identified and put on ART about 1 million. But then that 100,000 or so is now getting harder and harder to find. Of course, we have strategies like index and what have you that are helping us target our efforts better. But the idea behind recency is to help us identify those hot spots, those areas within our communities in provinces where we know have the highest estimated PL/HIV, so that we can even be more targeted as we try to approach the epidemic. So it's certainly, as you said, not going to change the course of an individual client, but from a public health standpoint, it's going to help us better target our efforts so that we can, find those 200,000 people that we still need to find. Hopefully.
Thank you. That's very, very helpful, Mary. You've wrapped that up very, very well. I see some people have already cheated and are voting. But in your cheating, again, the voting is a bit disturbing. Anyway. So we are relaunching the poll based on what we've learned. As Zambia approaches epidemic control, Mary has even said it again, prevalence will be a more useful metric for program planning than indicators of ongoing transmission. Is this true or false? Wow. Maybe we're using too many epidemiological terms. Dr. Mpeta, can you rephrase this? Because I'm worried about the voting I'm seeing here.
Yeah, it's kind of worrisome that it has even become, it's like it's unlearning. So what we are trying to say is, are we going to still rely on prevalence rates in trying to see if we are winning the fight against the epidemic, all right? Is it true that if we use the prevalence rate, it's going to inform us more in terms of, indicators for ongoing transmission compared to other parameters like new infections or recent infections.
Yes.
I think that's what this question is trying to say.
And as Mary said, as the program is mature now, will we be more interested in knowing where the old patients are who we've tested or treatment, or the new ones, so that we can go and intervene with PrEP, with
Yes.
condoms? So I think that's what the question is. I guess that helped, but I'm going to share the results now, Peter. Would you want to talk about what the answer is here?
So I think it was summed up pretty well. The answer is false. So again, prevalence can be affected by many factors, and often we expect it to stay pretty stable over time because people are living longer, for example. Whereas ongoing transmission, measuring ongoing transmission using tools such as recent infection will help us really respond in real time and target the response a lot faster.
Thank you very much. The second one, Dr. Mpeta, do you want to pick it up?
Okay, can we?
I'm just watching it. Kindly asking people to switch on their cameras.
Okay, so the second one is, in addition to a test for recent infection, which other test is included in the recent infection testing algorithm to reduce the likelihood of a false recent result?
This is impressive. This one's very clear.
So remember, there are still some people.
No, they are doing very well. I'm very happy. In addition to a test for recent infection, what did we see in the algorithm that helps us now differentiate this, okay, so that we reduce the prevalence of the false recent? What are the tests?
They always be.
You are a very bad person, Dr. Mpeta. This was going very well.
It's a good shank.
So what else have we seen? What other tests?
It's too early.
You know, there was a fancy term even used, basal. That's where we're going to go. I know in the next 3-4 years, this may become standard of care for patients,
but
not for them to know you are the recent.
You can see that out of the 50, or there are some people who haven't seen the polls.
How come the polls? Yes. I have.
It's shared.
I haven't polled. I haven't shared the results. Yes.
I think, who has voted? Why have people stopped voting? You know, one thing I've noticed, especially the people who join as individuals, they are shy. Don't worry, we can't see them.
I'm very shy when I'm at home to vote. I get a lot of things wrong from home, but here. Okay.
Yeah, so that's what we have noticed. Those who are facility-based, they normally vote. But the individuals, because you can see we have got 123, only 50, what? How many 70-something have voted?
So Siku and Precious, have you voted? I see you in Mongo there. We see you. We don't see your vote
here. The guys from Nakambala Urban Clinic, they've been seated and voted.
Okay, then. Your turn is coming the other week. Do you want to comment on this?
Oh, sure. So the answer is viral load, which we did very well.
Yeah, people did very well.
So again, viral load enables us to know kind of who is already on ART, so we can reduce those false recency rates.
So Dr. Okaya, please share your screen. We have a case of the recent infection. It's coming from Mwembeshi. Dr. Okaya. The case is presented by Sister Mary Mbulo. The case is coming from Mwembeshi, but it's being presented from Mount Makulu. So that's a lot of initiative on Dr. Okaya and team's part. We applaud you for that. Thank you very much. I don't think this was an easy case to find because it's such a new concept. I actually thought we wouldn't have a case, so this is impressive. Dr. Okaya, please go ahead. Satonda, they can't hear us. Do you want to phone? Okay, they're setting up. They're just setting up.
Yeah.
Dr. Okaya, please go ahead.
Yes, good afternoon. We have Sister Mary here.
Good afternoon. I'm Sister Mary Mbulo Chiluya, the presenter this afternoon. I'm the ART nurse at Mwendeshi Rural Health Center. We have a client who is 26 years old, female. She has a husband who has been on ART for HIV for 3 years now. On the 20th of June 2019, were in the 2 weeks later, and her HIV results were positive for HIV-1 and Abbott and Bioline. The vitals at the visit, the height was, the BP was 129/86, the weight was 69, and the temperature was 6.9. Family history. The husband has been on treatment for 3 years, and they've got 3 children who have been tested and they are all negative. The tests that were done on our clients, she was tested HIV positive on the 5th of July. And we did the CD4 count, which was 503. RPR 2 weeks later was negative. Creatinine 2 weeks later was 58. ALT was 16. AST was 32. Her hemoglobin 2 weeks later was 13.7. The client was commenced on an ART treatment, TDF, 3TC, and EFB. 2 weeks later, she came for review at the clinic. She only complained of some dizziness and heart palpitations. Otherwise, the client was well. The husband has been on treatment from the same clinic since 2016. And the husband has been treated on TDF, 3TC, EFB. He also completed INH prophylaxis as well. However, the VL was done in September 2018 after 2.5 years on treatment. The viral load was 50 copies per mil. In February, he was switched to TDF, 3TC, and DTG. In July this year, the viral load was repeated again. It was 20 copies per mil. CD4 count was 220, creatinine was 65, and ALT was 34. Index follow-up was done. The children, 3 children that they have, they are all negative up to now for 3 years. The client has denied having any symptoms of STDs in the past. The client has denied that she doesn't have any other sexual partners. And she also denied that she doesn't have any sexually transmitted diseases. She says sometimes they used to use condoms on and off. Our questions: how did this patient get infected? Number 2, could we have done more to prevent this infection, could we have done more to prevent this infection, which was the recent infection? Her CD4 was still high. Initial tests were indeterminate. That's the end of the presentation.
Mary.
Can we stop sharing?
I'm so sorry. I'll just summarize the case. We lost internet briefly.
Did we stop sharing? Where are they? We've lost internet.
Hello, Sister Jimala.
Yes, can I stop sharing?
Yes, unless the network has just continue sharing. I'm just going to recap the case. I'm so sorry we lost internet for a bit. We lost internet for a bit.
Okay.
So I'm going to summarize the case. Basically, we have a 26-year-old female married to an HIV positive partner on ART for the past 4 years, has been on ART. I assume that was when the HIV diagnosis was made. So this lady has been prudent. She's been going for HIV tests every year until the day came. It was indeterminate and finally positive. When you look at this case, it actually touches a lot of programmatic areas. There's the HIV testing services. She was being tested every year, not every 3 months, every year. And then you have index tests. They tested all her children and they found her to be positive, which is a recommendation, isn't it? Though, of course, in this one, you wonder why the index tested, because they were born before she was tested. Then also they've been doing viral load on the husband. He's now on TLD. His viral loads have been 50, 20. And they've also talked about TPT, which is the INH or INH. Essentially, this woman became infected in July 2019 and has been put on treatment. The question is, how did this patient get infected? How did, we are supposed to be psychic. How did this patient get infected, Dr. Jinwala? So do we have any comments from the network? We are sorry we lost internet for a bit. Okay, there's a question from Muntula. The answer, he's already answered question 1. He says, during the on and off condom use. Wow, Doctor, I guess this conversation was had while we were offline. Dr. Jinwala.
Can I stop sharing?
Yes, you can.
Yeah,
but do you want to comment on, because I think there's an answer for you, which says on and off condom use. I believe that was discussed maybe while we were off. Any comment on that, Dr. Jinwala?
Yeah, I mean, the history is that she hasn't been consistent with condom use. And if her husband at any point was not adherent to treatment and had a high viral load along the way, then the possibility that during that period of non-adherence, his viral load could have gone up and she could have been infected by her partner.
Mongo has raised their hand. Please stop sharing your slide decks, Dr. Jinwala. Please stop sharing. Mongo, please go ahead with your contribution.
Good afternoon. This is a very nice case. Our concerns are around when the husband actually started treatment, which could be a point when the woman might have gotten the infection. We look at the woman, the man actually starting treatment around 2017, and the woman started. Sorry?
It was actually 2016.
2016.
The last slide was, yeah, the year was wrong.
Okay, so if the woman or the man started treatment in 2016, that is good. But our concern is how often the woman was being tested. What could have been the challenge in this woman being a high risk since the husband was on treatment? Why were we not testing her every 3 months? Was she refusing coming to the clinic, or maybe there were other challenges that we could not get hold of the woman so that we could test them every 3 months, because we couldn't detect the positiveness of this woman as quickly as we could. It was like after 1 year, that's when we could actually get to know when the woman was actually testing positive.
Okay, I don't know, do we still have Bill? I think what Precious is saying, why did we test this woman every year, that is annually? Why didn't we test her every 3 months? Because she is a high-risk patient. She feels we could have picked it earlier. Marshall, please go ahead.
Yes, good afternoon, people.
Good afternoon.
Yes, this woman actually contracted the virus through sex, provided they were not using condoms consistently. Despite the man, the viral load was low. But remember, for someone to get HIV, there should be always a certain amount of virus present. So when the viral load is actually low, it doesn't mean that the person cannot transmit the virus. It just reduces the chances of transmitting the virus. Therefore, this lady actually just contracted the virus through sex. And that's according to us here. Then what was supposed to be done, this lady was supposed to be cancelled and being put on PrEP to reduce further, to reduce the chances of this woman from getting the virus.
Much, Marshall.
Thank you.
Thank you. So your answer, Dr. Oka, is they are saying she got it through sex. that's one. But I think maybe I think what people want to know is her point, isn't it? At which point did she get it from her husband? Considering he shows that he was equal to you, what is you is equal to you? How long should you be you is equal to you? I know Dr. Mangwela has said here, we need to message you is equal to you. This is based on the assumption that her only partner is her husband. All we know is that she has HIV. Where Dr. Amfet and Dr. Ziko.
Okay. Anyway.
Okay, Sons of Santa, please go ahead. I'm getting blank looks here. Sons of Santa, please go ahead.
Okay, one question came about the MOH. This gentleman has 2 non-detectable viral loads. There should have been no transmission. I think she's lying to you, partners.
Thank you, Sal. So there is a suggestion here that she got it through sex, but maybe with sex with someone else. That's a possibility. This is getting very interesting. Yeta, please go ahead. Yeta.
The ratio should be extended to more than one sexual partner.
The what?
So I think Yeta.
That was Kapata.
Hello.
Thank you for the presentation. Are you able to get me?
But Kapata, do you mind muting your microphone? We'll come to you in a minute.
Okay.
Yes, Pasha.
Yes, so this is Pasha from Yeka Hospital. I was acknowledging the richness of the case. It's rather a very, very interesting case that we are eager to listen to. I think for me, I would like to get more clarity on how the index testing elicitation was done. I think we kind of gave up on her when she said she didn't have any contacts and we let it be at that. Did we consider involving some experienced counselors to at least go back a second, third time to try and then more contacts? Because we're just assuming the possible source of the infection from the husband. So I think I would like to know more about how the visitation happened and what the plan is to continue the counseling and problem.
Thanks.
She came in last week, and Sister Mary will talk about her interaction.
This client, I talked to her personally as a counselor in the clinic, and I tried to probe if there was any extramarital affair, and she denied. She says, I've never had anybody, I've never met anybody sexually apart from my husband.
I think this case is a good demonstration of how difficult it is for people to admit that they have extramarital. They usually, the whole index testing, if we look at the whole list of people that are tested, it's usually just the husband and the children. We never really see many people who give the information that they have extra partners. There are very few who will admit that they have this girlfriend or an extra boyfriend here. So this really underscores the difficulty of getting that information.
Okay.
Even when you're a good counselor.
So let Kapata make their comments. Thank you, Dr. Oka. She's just saying that index testing can be, it's not that easy. Maybe she didn't disclose. We're not concluding that she got it from someone else. It's a possibility. Kapata, please go ahead with your comments. We saw you that you were really enjoying yourselves there. Please share with us the comments and contributions. Kapata. By the way, you have a very nice room for your echo. Well done.
Thank you.
Thank you.
We also wanted to comment that there's need to extend the ratio for elicitation.
The what?
The ratio. So I think people feel that we should have asked more and more and more.
Okay.
But she said, ever, that she. Okay, so there is few people feel there is a need. Dr. Mpeta, before we go to the next question, any comments on this case?
Do you want me to summarize? Or just...
Yes, yes.
Okay, yeah. I think like everyone else has said, first of all, we have to understand certain concepts about HIV. And this case actually does not make us deviate from what we are already doing vis-a-vis the U is equal to U and the non-use of PrEP when someone's partner is suppressed. So what we have to know and what we have seen actually from these studies is there was no transmission, all right, when partners remained suppressed or undetectable as compared to those. We've seen that in these studies, those that actually ended up being positive, when in the study they were probed further, they actually found that they contracted the HIV virus away from their normal partners or their usual partners. So it could be the case here. We cannot completely rule it out. And this case definitely reminds me of a similar case that I had. It wasn't the case of HIV. It was the case of, secondary infertility, where I was treating this couple which came in for secondary infertility, and all the tests, of course, for the lady were normal. She was, genetically, physiologically, and anatomically normal to actually have a child. The other child was 5 years old, but they were unable to conceive. And then when they brought in the husband, of course, we found that the husband was incapable of fathering any child. Now, she only accepted at that point. And previously, she was always saying, I have never cheated. I cannot cheat on the husband. But later on, she had to agree that actually even that child wasn't the husband's. All right? Now, this is a typical case with adults, not like children where if black is black with children. In adults, you really have to employ a lot of skills for you to find out. Now, if we assume that all was equal, all right, let's assume that she was indeed telling the truth. What are the chances of getting infected from the husband, okay, in a husband who presumably is suppressed? Now, we have seen that the suppression the level of suppression in the husband has been quite good. And last year, he was even transitioned to TLD, of which we know by the guidelines, that's like 1,000 and below. So this is a patient who had previous, suppression. Now, this could have happened that if we maybe have to ask on the side of the husband, if there was a point when probably he missed even a week. Remember, even just a week, you can get a high viral rebound. And at that time, if you happen to meet with your partner, they have got the highest risk of infection. And then you get back and you get on treatment. And then by the time you come to the clinic, even in 3 weeks with dolutegravir, you find that is already suppressed. That is a very big possibility. So the other thing that we have to, let's not really focus and crucify this woman and put her on the crucifixion of, cheating, but let's also look at the husband, okay? Did he actually remain on treatment? Because it's very possible. And remember, if he knows that we are probing these questions because his wife now is HIV infected, no one wants to live with that guiltiness of having infected another person. So definitely he's going to say, I was taking, all right? So that's also a possibility. But if we were to do this counseling in a way that there's no judgment on either the woman or the husband, then we can actually try to find out at what point exactly did this mistake happen. Number one, if this infection came from the husband, there was a possibility at one point he must have maybe missed a few doses, even maybe up to a week, got a rebound viremia, and then happened to have met the wife, and then she got infected. Secondly, there's a possibility that the husband remained suppressed through and through, but the wife at one point must have, bumped herself in a small stone and found herself in another man's arms, and then she ended up contracting HIV. That is also a possibility. Now, we can only find out if we do a good counseling.
Thank you so much. So I think Dr. Mpeta is saying we need to be very tactful. This is a sensitive situation. And it tells us the importance of continuous patient education. Just because you are you to you, because your partner is you to you, doesn't mean that you won't get it from someone else. And then there's research around what's happening in the genital area of women in terms of the presence of STI. That's a lot of studies that still need to be done. I think Precious has addressed the second one. Precious, would you like to take the second question? Precious and Susiku. They say, could we have done more to prevent this infection, which clearly was a recent infection? Sister Mary says the CD4 is still high, and we are seeing the transition from indeterminate to a definite positive. Could we have done better to prevent this infection?
For sure, I would have done better to prevent infection. Firstly, by testing this woman every 3 months, and like year tests that we were doing, then would have gone ahead to initiate her on PrEP, because this woman was very much eligible for PrEP. So if we PrEP would have prevented her from getting the infection. So continuous counseling, actually couple counseling was going to be best. I think it has been silent on. So if the couple was coming each on their own to say, I'm going for a test, I think that was not due. So couple counseling was a good way to go, so that both of them, if we have to cancel and also find out certain issues like maybe an extra affair, would have found out counseling. So it did those three things. I think prevention of the infection could have happened, especially they were suppressed.
Okay, so Precious suggests we should have done closer monitoring and checked for that extra affair. It implies that you can have one affair, then another one that's extra. So anyway, she meant any extramarital affairs. Dr. Mangwela, I've unmuted you. I've seen you saying something on you. Is equal to you. Would you like to make a comment?
Sorry. I thought I was still muted. Yeah.
No, you're not.
Yeah. When we went out during the U equals U campaign, we talked to a lot of people in the community, and quite a few times you would find people asking about whether if someone is suppressed and detectable, they could stop taking medicines. So I think as we are spreading and educating our patients on U equals U, it needs to be very clear to them that they still need to take their medicine all the time. Because if they do relax, indeed, you may have episodes of people infecting their partners because they think just because they were undetectable the last time, then they'll remain undetectable.
Thank you so much. Well said, Dr. Mwangela. Dr. Mpeta, would you like to comment on this one before we wrap up? Could we have done more to prevent this infection? I must mention, next week people are going for the guidelines. We've gathered so much from this network that we realize needs to be addressed. We need to be crystal clear in our guidelines when we give a guideline so that we don't end up having a public health failure because we don't package our messages properly. Dr. Mpeta, could we have done more to prevent this infection? Dr. Zico.
Okay, I want to comment first on the use of PrEP in this particular couple. Firstly, use of PrEP is in a discordant couple is done when the other partner who is infected has a very high viral load, and that's when you have high risk of infection. But in this situation, you have this partner who is infected but is suppressed, and so PrEP was not indicated in the patient. But in terms of other strategies that would have been useful to prevent infection, I would suggest that if you have such a situation, couple counseling is very important so that you continuously provide adherence counseling to the HIV positive partner, and you also provide prevention messages to the partner who is negative. And so if we have the second situation where Dr. Mpeta mentioned that it's possible that the partner would have had skipped some medications and then had a high viral load which led to infection, that would have been prevented with ongoing prevention messages. And then for the other partner who was negative during those counseling sessions, it would have been important that that person is also engaged in prevention messages, and that would have also tried to reduce the risk. But of course, counseling is one thing, and implementation by the people who are being counseled is another. So I think if that was done, would have been covered on our part.
Thank you so much, Dr. Zico, for summarizing the second response. Thank you so much, Dr. Mpeta, for summarizing the first response. Dr. Rokaya and team, Sister Mary, do you have any comments, or are those recommendations clear? You can unmute yourselves. I'm trying to, as we wrap up, are those clear? Are the recommendations clear, first of all?
Yes, they are. And as we continue to see the patient, we continue to probe into other sexual partners. But I wanted to take this opportunity to say that this is the same issue that came up from the ECHO trials when they were looking at contraceptive use in women. The women come regularly for family planning and they have a contact with the clinic, and then they still continue to seroconvert. So we need to do more in terms of our prevention messages. Just to complete.
Thank you so much, Dr. Rokaya. In terms of us talking about prevention, we are giving women family planning. The ECHO trial is another big trial that we won't go into. I know last time I said ECHO trial, people wanted to know. There's an ECHO trial, now there's ECHO. ECHO trial is basically about, they're trying to see if HIV is more common in women that are on contraceptives. It just shows that they are on the various types of contraceptives to see which ones are more prone, whether it's an injectable, an IUD, or the implant. They found actually that there was no difference in the numbers of HIV infection. They were the same. However, the incidence among people using family planning is quite high. So this is the target population we really should be targeting for PrEP. Dr. Rokaya, well done for summarizing that so well. Thank you for this case. It has all the programmatic areas we deal with in HIV. We'll see you next week. What's the topic next week, Davis?
MSL supply chain system. Okay, so for next week, we are going to have our colleagues from Medical Stores Limited, and that's Ilitongo and Mercy, and they'll be talking about medical stores limited supply chain system. So they'll share with us what it takes for them to take the commodities or supplies to different facilities across the country, and some of the challenges or indeed successes that they have had in the past few years as they do their job. So that's next week at 14:30.
Thank you so much, Davis. I think a special thank you to Peter. He's been very patient. Thank you so much, and well done. We enjoyed that. Thank you all for joining us. See you next week. And it's a wrap.